do when we bring patients in for this kind of monitoring is we pick one of the two medications that we either think we're going to maybe remove ultimately to switch out for a different one, or one that we think's not working or you don't like. LTM stands for long-term video EEG monitoring. People referred because they're having spells. What we have on the 10th floor is private rooms where we can set patients up with EEG and video and all the safety monitoring with our nurses in the hospital 24/7, so over several days, which is not available at many local community hospitals.
Since I was in 8th grade, that was when I was 14. Now I'm 19 years old and still have it. Not really nervous, kind of just want it to get finished and see what goes on from there.
We have a multidisciplinary approach with numerous specialists that participate in this evaluation. We have neuropsychologists, licensed social workers that specialize in epilepsy, psychiatrists, neurosurgeons, and neuroradiologists that participate in each patient who comes through our doors. Every patient is different, and every patient's seizures are different. Even though we have certain diagnostic syndromes that may define multiple types of seizures in epilepsy, we try to treat each patient very differently from any other case that comes through our doors.
But because medications aren't working, we feel that taking the medications down to see the seizures is something that really has to happen so that we can actually see the event, find out what it is exactly, and find out why it is the medications aren't working.
There are a lot of patients that are very nervous that they won't have a seizure, nervous that they will have one, and to what degree they'll have it. So our nurses are constantly watching at all times. We not only have the cameras that go downstairs to the EEG lab, but we also have cameras out here.
Hi, are you okay?
Yeah, I pushed the wrong button.
Oh, okay.
And we have a couple ways that will keep you safe. We put you on a cardiac monitor, which helps us watch your heart. We'll also put you on oxygen monitoring. We also give you a bell to push, which will alert us if you're feeling strange, if you're feeling anything, any kind of seizure activity coming on.
Along with that, you have 24-hour video monitoring, so if a patient does have a seizure, that's also a useful tool for the docs to try to diagnose what type of seizures they actually have.
Our goal for the monitoring period is very patient-specific. So with each patient, we discuss ahead of time what our joint goal is. For many patients, it's to record a seizure or seizure activity during the video EEG. For other patients, we may be looking at how frequently the seizures occur, or maybe changing medications more quickly and more safely in a hospital setting. So for every patient, the goal may be slightly different, and we work with the patient to come up with those goals together.
Even though when I told you I was sending you in, I wanted to get a seizure to see what it was. Once I realized that you were very likely and easily going to have a grand mal seizure, generalized seizure, and had my diagnosis, I decided to change gears, and it's amazing. I learned so much more by bringing my patients into the hospital, where I have time, a little more time to see them at different times of the day, interact with their family, and then the different specialists that have their different areas of expertise and are delving into different aspects of patients' lives that the epilepsy has affected.
The one thing that was sort of interesting was we knew he was left dominant, but we also saw some activation in the anterior temporal lobe at the temporal tip.
And he's going to come back in a month with some follow-up with me and repeat imaging, and we can work out when he should come to your clinic as well.
Yeah.
Not everybody who's admitted to the LTM unit is here for a surgical consideration. Some patients are here to review their treatment regimen, and part of that is often they're taking a large number of anti-epileptic drugs and other drugs, which can in and of themselves affect brain function.
What I tell patients is that we're going to learn something about them, whether they have a seizure or they don't, but that most likely they are going to have a seizure, given their seizure history and given the fact that we are, in this controlled environment, going to be tapering them down from their medicines or sometimes tapering them off of their medicines.
Is it garlic in there? I was diagnosed with adult onset epilepsy. Around '07, I started having these smaller seizures, and we couldn't get to the root of what the problem was. I was bouncing from job to job. I got off my career path, and it was very frustrating for me. It all just fell into place within about a week or two that I got to meet with Dr. Dvorsky, Dr. Bubrick, and they admitted me immediately at Brigham and Women's, and it was a breath of fresh air. Given that I was admitted for an extended period of time, they were able to get it, and I think that was a major key. That was the key for me for them to observe that actually happening, and that could only happen by having me there for an extended period of time.
One of the reasons we bring patients in is not just to take them off medications, but also to encircle them with a whole group of specialists in a short period of time, focus on the problem, and figure out which of the factors is most important at that time and what we can do more of. I always learn something when somebody is admitted to the hospital. We're going to go to a medication that is probably the first choice for a young man such as yourself.
At the end of the long-term monitoring, our physicians here will contact the referring physician directly and discuss the results and any medication changes that have occurred or any further suggestions for treatment. We really have to, because people are coming here and this isn't their regular place of care. So the communication is key in sending them back out to the community and making sure they have the proper treatment they need.
It's funny because I think back, and I used to wake up every day dizzy, and every day, like, in a high on a drug. It felt like like you were spaced out. But now the norm is just clarity, and it's great. Work is going well, and I'm in a good place.